Hello and welcome to Neurocognitive Consequences of ARDS. My name is David Woodruff and I'm the president of Ed for Nurses, where we empower nurses to be extraordinary. This is part of our 2-minute EBP challenge. You can find out more by going to edfornurses.com and signing up for your own 2-minute EBP challenge. Every Friday we send out a question, and on Monday you get the answer to that question right in your email. Makes it very easy and convenient. As the name implies, it's something that you should be able to do in 2 minutes to help you to stay up to date with evidence-based practice. Sign up online by going to edfornurses.com. You can also connect with us on Facebook. Go to facebook.com/edfornurses or just search for us, Ed for Nurses, on Facebook and get more empowering information and content. Today we're going to be talking about ARDS and acute lung injury. Acute lung injury is actually the thing that occurs that causes the patient to develop ARDS. So first of all, we have the acute damage that occurs to the lung, followed by inflammation that occurs in the patient's lungs, then followed by the systemic inflammatory response syndrome. This is the thing we call SIRS. This is overwhelming, out of control inflammation. Another way I've heard it described, which is very appropriate, is malignant inflammation. That causes the condition that we think of as being ARDS, acute respiratory distress syndrome. But the underlying problem that causes this sequence of events is going to be the acute lung injury. So just so that you're getting these definitions down and you're separating these things out a little bit, it's the acute lung injury that causes the patient to develop ARDS. So I don't want you to get confused with terminology as we're talking here. Some of the risk factors for acute lung injury include sepsis, lung trauma, multiple trauma, pancreatitis, blood transfusions, and shock. Now, these are some of the highlights here. So these are some of the main causes of acute lung injury in your patients. Certainly other things can contribute to acute lung injury as well. Aspiration being notably one of the ones that was left off the list. The picture we have here is an X-ray of a patient who has ARDS, and you see the diffuse whiteout on the chest X-ray. It's kind of like foggy throughout the lung fields. Instead of having this nice dark lung tissue that contains a lot of air, our lung tissue here contains a lot of fluid in the alveoli. This is called an alveolar pattern, where it looks like you're looking through fog at your chest X-ray. Now, normally this would start in the bases and work its way up if it was cardiogenic in nature, but since it's caused by ARDS, we're seeing the diffuse pulmonary edema throughout the lung fields. Okay, now I've mentioned this already, but let's just talk about these definitions. Acute lung injury, ALI, is the injury that occurred to the lung. So the patient vomited and aspirated, and the aspiration caused the injury. Then the process of malignant inflammation that occurs there after the acute lung injury is the acute respiratory distress syndrome. So this is the ARDS component. So just so that you're clear on these terms, you're going to see these used in the literature, and a lot of times we talk about acute lung injury. It's not a separate process from ARDS. It's more kind of the precursor, I guess you could say. But in most cases, when we're talking about acute lung injury, we're also talking about this malignant inflammation that occurs thereafter called ARDS. Now, what happens in ARDS is we get inflammation that is out of control. The inflammatory process causes 3 main processes to occur, that being vasodilation, capillary permeability, and clotting. Now, the capillary permeability is going to cause the patient to develop edema, and the kind of edema that forms here is going to be thick. It's going to contain inflammatory debris and dead cells and proteins. What does that sound like? That sounds like pus. Yes, this is thick. type of edema. And once it gets in the lungs, it's hard to get out. So we don't want to create a lot of edema in our patient with ARDS because we're not going to be able to get that fluid back out again because it's pulmonary edema caused by capillary permeability. Next, we get clotting, millions of tiny little microclots occurring in the lung, and that causes a decrease in perfusion. The decrease in perfusion causes hypoxia. The lung's response to hypoxia is to cause vasoconstriction, thinking that it's not having enough blood pressure in the lung in order to have good perfusion. But unfortunately, what that does is that further worsens the decrease in perfusion. So what happens is we get into this vicious cycle at the bottom here, which is the refractory hypoxemia. Now, you may have noticed I skipped over the first part there, which is the vasodilation. Vasodilation hides the problem by maintaining the oxygenation in our patient with ARDS until the patient crashes. So even though it looks like it was a sudden event, ARDS is not a sudden event. It occurs in phases over a period of time. And that period of time could be maybe an hour, several hours, or even days. But there is a progress to this inflammatory response that occurs in ARDS. It doesn't just happen suddenly, although in many cases we notice the signs and symptoms suddenly. There are long-term effects that occur as a result of ARDS. The picture here showing some of the lung destruction that occurs in ARDS with lots of atelectasis and lots of hyaline membrane formations. And hyaline membranes are scar tissue, so that's going to seal that alveolus shut forever, resulting in physiologic long-term effects. Psychologic long-term effects can also occur, and cognitive. And that's what we're going to be talking about today, are the results of a study that was done that looked at the psychologic and cognitive long-term effects of ARDS. What they found was about 62% of our patients who recovered from ARDS had anxiety, cognitive impairment in 55%, post-traumatic stress disorder occurred in 39%, and depression in 36% of our patients who recovered from ARDS. So obviously very common that the patient's going to have some long-term consequences. In addition, there is memory impairment, about 13% of patients. Verbal fluency decreased in about 16%, and executive function was impaired in 49%. Now, all of these impairments that are occurring as a result of the patient who's had ARDS might be the result of hypoxemia. It might also be the result of maybe hemodynamic abnormalities or fluid shifts within the brain. We really don't know. And the authors of this particular study suggest maybe it's the hypoxia causing a lot of the problem. However, we don't know, and we will need more research to be able to validate those assumptions. She says, I was going to prescribe an anti-anxiety cream. You have worrywarts. Okay, well, our patients who recover from ARDS do not have worrywarts. They have actual clinical anxiety, depression, post-traumatic stress disorder, and cognitive dysfunction as well. If you'd like to find out more about this particular article, you can find it in the American Journal of Respiratory and Critical Care Medicine, Dr. Mickelson and colleagues, the Adult Respiratory Distress Syndrome Cognitive Outcomes Study, Long-Term Neuropsychological Function in Survivors of Acute Lung Injury. Thank you for joining me for Neurocognitive Consequences of ARDS. My name is David Woodruff, and until next time, bye now.